Let's now walk through the gait cycle phase by phase, focusing on the hip. At initial contact, the hip is positioned in approximately 20 to 40 degrees of flexion, slight adduction, and slight external rotation. This positions allows the limb to accept load and positions the abductors for upcoming single limb support. The primary muscle activity here is eccentric activation of the gluteus maximus to decelerate hip flexion and prevent excessive trunk flexion. The glute medius is already active in anticipation of loading, stabilizing the pelvis in the frontal plane. The deep hip external rotators contribute to femoral head stability within the acetabulum. The dominant external moment at the hip is flexion. If you observe a forward trunk lean at heel strike, suspect inadequate hip extensor control or pain inhibition. During loading response, the demands on the hip increase significantly. Gluteus maximus reaches peak activation to control forward trunk momentum and assist with shock absorption. The gluteus medius and minimus are strongly active to prevent contralateral pelvic drop as the body transitions fully onto one limb. The posterior fibers of the adductor magnus assist with hip extension and contribute to joint stability. Failure to adequately control this phase results in either a Trendelenburg gait or a compensated Trendelenburg gait with a lateral trunk lean. Pain-related inhibition during loading response often produces gait deviation even before measurable strength loss occurs. During mid-stance, the hip moves towards neutral extension. As the body's center of mass passes over the foot, apparent hip extension is aided by posterior pelvic rotation. The gluteus medius and minimus maintain sustained, mostly isometric activation to stabilize the pelvis. The iliopsoas shows minimal activity because the hip is extending primarily due to body momentum rather than active muscle contraction. This is where hip abductor endurance matters most. Patients often look fine for a few steps, then deteriorate. Terminal stance is characterized by peak hip extension, typically 10 to 15 degrees. This phase is critical for step length, propulsion, and energy transfer. As the body moves forward over the stance limb, The hip reaches its maximal extension just before heel off of the contralateral limb. At this point, the demand on the hip extensors has decreased substantially. Instead, the hip flexors, most notably the iliopsoas, begin eccentric pre-activation. This eccentric activity is essential for controlling the rate of hip extension and storing elastic energy for the upcoming swing phase. The rectus femoris also begins to activate, contributing to both hip control and preparation for knee flexion controlled during pre-swing. Gluteus medius activity tapers as the pelvis becomes more stable with the onset of double limb support. If hip extension is limited here, whether it be due to joint restriction, soft tissue tightness, or pain, you will consistently see reduced contralateral step length and slower overall gait speed. Pre-swing represents the transition from stance to swing and is often overlooked, but it is a high demand phase for coordination. During pre-swing, the hip begins to move out of extension and toward flexion. Although the hip may still be in approximately 10 degrees of extension at toe off, the direction of this motion has been reversed. The primary drivers of this reversal are concentric activation of the iliopsoas and the rectus femoris. The iliopsoas is the key initiator of swing. It produces rapid concentric hip flexion, while the rectus femoris assists with hip flexion and simultaneously modulates knee flexion. The hip adductor group, particularly adductor longus, contributes to limb advancement and medial lateral stability. Delayed or hip flexor activation during pre-swing leads to reduced limb clearance, delayed swing, and decreased cadence. During initial swing, the hip flexes to approximately 20 degrees. This phase is dominated by active muscle contraction. The iliopsoas demonstrates peak concentric activity during initial swing, making it one of the most metabolically demanding phases for the hip flexors. The rectus femoris continues to assist with hip flexion while also influencing knee motion. The sartorius contributes to hip flexion and assists with limb positioning. Although this phase, the gluteus medius on the swing side plays a subtle but important role in controlling pelvic position and contributing to accurate foot placement. The clinical pearl: weakness during initial swing often manifests as circumduction, excessive pelvic rotation, or vaulting on the contralateral limb. Mid-swing is primarily a momentum-driven phase. Hip flexion typically reaches 20 to 30 degrees during this phase, allowing adequate toe clearance, muscle activity, decreases significantly as the limb continues forward due to the momentum generated earlier in swing. There's minimal activity from the hip abductors and extensors during this phase under normal conditions. Clinical Pro, excessive muscle activity during mid-swing often indicates compensation for earlier deficits, such as an inadequate hip flexor strength or poor swing initiation. Terminal swing prepares the limb for the next initial contact. The hip reaches approximately 30 degrees of flexion. At this point, the hip extensors, particularly the gluteus maximus, activate eccentrically to decelerate the forward motion of the thigh. This eccentric control is essential for positioning the limb safely and efficiently for heel strike. The gluteus medius and minimus pre-activate in anticipation of weight acceptance, while the adductor magnus assists with the limb alignment. Clinical Pearl, poor eccentric control during terminal swing often presents as a hard heel strike, instability at initial contact, or excessive trunk motion.